بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على سيدنا محمد وعلى آله وصحبه وسلم. I'm sorry there are urgent experiences that prevented me from being with you, from enjoying the company of old friends. I have come to this country. Saudi is my second home. In 1971, I was in the University of Riyadh. I established the first psychological clinic in the university. I have so many good friends in the field that I really wanted to come and to see them. However, I have to absent myself from being with you, and I was asked to give a synopsis of the paper, the way I would have done it if I were there. As you can see, the title of the paper is an innovative treatment of a rare exaggerated obsessive-compulsive reaction to smell. The patient was a 43-year-old Malaysian of Indian origin. He developed this strange kind of compulsion to bad smell by taking showers and changing his clothes. He comes to work with a bag of clean clothes, and in Malaysia here, because it is a warm and humid country, in every department in the government or in non-government institution, there are also showers, places for showers. And many people during the lunch hour would take a shower. This man used this facility very well. Whenever he is a cleaner, his work is a cleaner. So whenever he smelt the smell of rotten dead rats or anything that is offensive, he will run, take a shower, and change his clothes. The origin of this disorder came from his mother when he was still a child. She used to be to show very dramatic, exaggerated response to the smell of fish. And in fact, the smell of fish is his most offensive smell. Now, this young man, in differentially diagnosing him, I spoke about its similarity, the similarity of his disorder with ORS, known as olfactory reference syndrome, and with also with bromidrophobia, and with obsessive disgust. But as I said in my paper here, whatever the differential diagnosis, whatever the diagnosis, the treatment is the same, and that is exposure and response prevention therapy. Here, I would like to say that before going into this, that he was first referred to a psychiatric hospital where he was given a drug. The drug caused him headache and difficulty to urinate, and maybe these were side effects of a tricyclic drug, and he really felt very bad. Things were getting worse. He was moved to another hospital where he was given an anti-anxiety drug. It made him much better, but the OCD continued unabated. This made the psychiatrist transfer him to where I was working in Malaysia at the time, and I used a two-phase kind of psychotherapy, or behavior therapy, cognitive behavior therapy. The first phase was a phase of cognitive restructuring, the phase of the use of the new approach in behavior in CBT, that is mindfulness, acceptance, and restructuring, relaxation, things that would actually prepare him for the for the second, more difficult phase. Now, this exposure and response prevention was developed by Victor Mayer in 1966. I am happy to say that I have witnessed the very first case in history in which Vic Mayer treated a London pathologist. It was a man. This famous psychologist by the name of Jack Rackman mentioned that it was a woman. No, it was a man. And the man was a London pathologist. He was working in the University of London. And he was like most of you, and he was a workaholic. So he continued working on this particular virus or germ or whatever it was. And then he felt very tired. So he decided to take the specimen home and continue his work. He took the microscope in one hand, his bag on the other, and the specimen between his fingers. And he tried to open his car, but then the specimen fell on his seat, and the dangerous germs filled the seat. So he panicked, he ran, he brought disinfectants, and this caused him to develop this terrible OCD of the compulsion of hand washing. I do remember this man very well. When he came into the hospital, as a white man, his hands were actually red and sore. Vic took him to a room in the hospital where he cut off the water from that small room. And then he would intentionally contaminate his hands and prevent him from washing. This was really a very, the man really developed a lot of anxiety. He would only give him Valium. At times this man liked classical music, so he would play music for him to relax him, but not to allow him to wash. In fact, at one time, Vic brought me into the, to take part in the therapy, because at that time, this was about almost 50 years ago, as a black man at that time, the British were still racistic concerning black people. And this man, when he saw me and I came nearer to him, he really almost panicked, because he was afraid that I may touch him or touch his hands. But anyway, in a few days, this man simply improved dramatically. This as use of exposure and response prevention is rather difficult for the patient. And as I said in the literature, many patients with OCD would prefer to take a drug, would prefer to have some other form of therapy, avoiding this painful aspect. And this is where my contribution comes. After the first phase, in which he could see the absurdity of washing away a contamination of a smell by taking a shower and changing his clothes. After this phase, then we started the next phase. The next phase was actually response prevention, but in a lighter way, in a gradual way. There are two contributions in this paper. The first one is that I used a gradual approach. It was more like the old systematic desensitization method. I would let him gradually concentrate on this issue, and with relaxation, with mindfulness, with this, he imagines this aspect of smelling bad smell. Now, after this phase has gone finished, then I came to the actual new innovation, in which I brought to the clinic a rotten fish in a bag. then I will ask him to smell the rotten fish. When he becomes tense, I brought with me a bottle of eau de cologne, of perfume. Then I will press it, and the spray will come into his face. He will smell it. Then I tell him to relax, and during his relaxation, again I go through the whole approach. When he feels better, enjoying the fragrance, he begins to understand from what I say to him that it is really absurd for him to feel better with this fragrance, as if it has washed away the contamination of a smell. Then when he's ready, then again I let him smell, but this time not only for a few seconds, to try to elongate the time gradually. This had been done until after the first and second sessions. I would give him the fish to take home in the bag, and the bottle of perfume, to try to experiment at home. Gradually, the length of time increased until he was able to continue smelling the rotten fish for up to 5 minutes, and then to use the fragrance. In a few sessions, as I mentioned in the paper, he really felt much better. And it was he who said that, who asked for the treatment to be terminated, and that he feels okay. But all the time he said, I will continue taking this bottle of perfume with me. Whenever I smell a dead rat or something, then I will use the perfume. So here the contributions are first the gradual treatment, which to me, I have devised a system long ago in 1966. This was published in a paper that was titled A New Technique for the Systematic Desensitization of Pervasive Anxiety and Phobic Disorders. This was published in the Journal of Psychology in the US a long time ago. And in this paper, I was actually criticizing the SR approach at that time of behavior therapy. So what I decided is that the hierarchy is only a sample, and that we should go not only vertically but horizontally. Once a certain aspect in the hierarchy has been desensitized, then the patient begins to talk about other aspects that he had been feeling. There is no time for me to dwell on this, because this kind of therapy, I remember, though I was a student at that time, a trainee of Victor Meyer, but he liked it and used it, and he gave it the name behavioral psychotherapy. Since then, this term became much more popular. So the other approach, which is a contribution, I think, is that of the use of a stimulus opposed to the one that causes the OCD, and that is the perfume. And then the third contribution is the inoculation of cognitive restructuring, of mindfulness, and of acceptance. I think that mindfulness and acceptance, I have been using this before even I knew about it. I have been using it since 1967, and I have borrowed it from traditional Muslim healers in my country. It is already, this thing had been used, mindfulness and acceptance within a spiritual context have been used for centuries. It is unfortunate that our Western colleagues, Western scholars, take a flight all the way from America or from Europe, all the way to the Far East, to borrow from the works of Buddhism and other aspects, we are nearer to them. And our early Muslim scholars have already wrote and have already applied cognitive behavior therapy. More than 12 centuries ago, I have a book has been just published for me in London on the works of Al-Balkhi in this respect. I think I had already taken probably more than the time that is allowed for me, so thank you very much indeed.